This is Dr. Subi Sonke. I am working as a senior resident in the Department of Dentistry in Stanford. Today I am going to present a paper on the topic prospective rehabilitation of hemimaxillectomy with follow bulb obturators. Contents includes introduction, challenges, types of follow bulb obturators, case report, conclusion, and references. Starting with the introduction. Congenital or acquired tissue defects of the palate or contiguous structures need special processes for proper sealing. So, acquired defects are mainly due to surgical resection of the tumors. These defects are mostly complex as they involve skin, bone, muscle, cartilage, and multi-layers of the mucosa. Therefore, the reconstruction of such type of defects is often challenging. What are those challenges? Like if the defect is large, then closure of the defect is difficult. And after resection, it is difficult for the patient for mastication and swelling. There is challenges with speech as well as aesthetics also get compromised. So to solve those issues, maxillofacial prosthesis is given. These maxillofacial prostheses were used to close a congenital or acquired tissue openings primarily of the hard palate and or contiguous alveolar soft tissue structures. Rehabilitation of maxillary defect with obturator has been well defined as comprehensive treatment care to achieve optimal success in improving post-treatment quality of life. So, on the basis of extent of the involvement of the defect, the prosthesis may differ in shape and size. So, ideally, the prosthesis should be easy to construct. It should be lightweighted so that it will provide better retention, support, and stability, and it should be functionally acceptable by the patient. So, for a definitive palatal obturator, the undesirable weight of the prosthesis becomes a challenge as it will affect the retention, stability, and support of the maxillofacial prosthesis. So, it is needed to make a lightweight prosthesis, or the bulb of the obturator should be made hollow. So, these hollow bulb obturators are of two types. One is the open bulb obturator, other one is the closed bulb obturator. This is the open bulb obturator, and here the bulb of the obturator is closed. So, what we should prefer? We should always try to prefer a closed bulb hollow obturator, as in case of open bulb hollow obturators, although this portion is hollow, but the nasal secretions will get accumulated inside this hollow cavity only. So in turn, it will try to increase the weight of the prosthesis only, and it is difficult to cleanse the prosthesis properly. So it is always desirable to make a closed hollow bulb obturator. So now proceeding with the case report. See, this is the 55-year-old male patient referred from the Department of Oral and Maxillofacial Surgery for the fabrication of surgical obturator. Surgical obturators are the ones which are fabricated before the surgery, and it is given immediately after the surgery. It will aid in post-operative healing. It can be used to hold the dressings at its place. So this is the pre-operative view of the patient. He is having tumor in the hard palate. So first we made the impression of the patient. After making the impression, we pour the cast. After pouring the cast, these are the margins which are dictated by the surgeons for resection of the tumor. So accordingly, we will remove the teeth from the cast and we will prepare the cast for mock-up. Then we will do wax up over it, and this is how the surgical obturator is made. So this is how hemimaxillectomy has been performed, and after hemimaxillectomy, immediately this surgical obturator is placed. Then patient lost for the follow-up appointment, so interim obturator has not been given. Patient came reported to the department after 6 months. So this is the healing which takes place after 6 months. Now this is the time for fabrication of final obturator. So during this, first we will make the final impression of the upper arch like this. Then we will do the preparation for cast partial denture. Then this is the trial of the cast partial denture. Then after this trial, we will do the bite registration. After bite registration, we will do the trying of the teeth. One of the major problem with these type of patients is on the defective side, the cheeks got sunken. So to increase the cheek fullness, here we added the extra bulk of wax. Okay. Now coming to the processing of the denture, which is the most important step. Because in this step we are going to make the bulb of the obturator hollow. So to make it hollow, there are many ways. We can use the mixture of plaster and putty. We can use the um, salt. But in case of salt and mixture of plaster and putty, we need to make two holes in the obturator after processing. So from one hole, we are supposed to inject the water syringe so that it will flush it off the remaining in salt or mixture of plaster and putty from in the cavity, from the obturator cavity. But it is difficult to remove it completely. So here in this case, I tried to make a hollow bulb obturator with aluminum foil. So here, after here in this cavity, or in this cavity, I added tin foil, and this is the region where I have given the cheek fullness. So in this region, I added thermocol balls, because these thermocol balls are weightless, so it will not add the weight to the processes. So after processing, this is how we will get our partial denture, and this is the bulb portion of the obturator. So this is how we remove the tin foils, and the inside cavity of the bulb will become hollow. Now we will put this hollow bulb over the cast partial denture, and we will seal the peripheries with the cold cure acrylic denture based resin material. So this is how the final occlusal view of the processes, and this is the intaglio view of the processes. Here you can clearly appreciate that the borders are nicely merged. So, and this is the final occlusal view in the patient's mouth. This is the pre-operative picture showing the sunken appearance of the cheek, and as we added the cheek plumper, here you can clearly appreciate that the sunken appearance got improved. So at the last, I can conclude that the rehabilitation of these maxillectomy patients is complex, simply because of the fact that designing of partial denture framework in such situation has its own limitations, especially the factors that are related to the designing of the processes. Besides that, the bulb was made hollow with closed end to aid in speech resonance. It will reduce the weight on the unsupported side, so that it will reduce the self-consciousness of the patient and also enhance the aesthetics by allowing the addition of the cheek plumper. These are my references. Thank you.